Question 1. Operational review demonstrates a cluster of unusual respiratory symptoms reported by healthcare providers in a specific geographic region. The public health department needs to rapidly identify potential causes and implement control measures. Which study design is most appropriate for an initial investigation to efficiently identify potential risk factors and guide immediate public health actions? Option A. A randomized controlled trial to test the efficacy of a novel antiviral medication. Option B. A case control study to compare past exposures between individuals with the symptoms and a matched group without the symptoms. Option C. A cross-sectional study to determine the prevalence of respiratory symptoms in the affected region. Option D. A cohort study to follow a group of individuals over time to observe who develops the symptoms. Correct answer is B. A case control study to compare past exposures between individuals with the symptoms and a matched group without the symptoms. Explanation. This scenario presents a professional challenge because the epidemiologist must select the most appropriate study design to investigate a potential outbreak while adhering to the principles of scientific rigor and resource allocation. The choice of study design directly impacts the validity of findings, the ability to establish causality, and the efficiency of public health interventions. Careful judgment is required to balance the need for timely data with the limitations of different designs. The correct approach represents best professional practice because it prioritizes a design that can efficiently identify cases and potential exposures in a situation where an outbreak is suspected but not confirmed. Case control study allows for the retrospective investigation of exposures among individuals with the outcome, suspected illness, and a comparison group without the outcome, making it suitable for identifying risk factors for rare or newly emerging conditions. This aligns with the ethical imperative to protect public health by promptly investigating potential threats. An incorrect approach that relies solely on a cross-sectional study would be professionally unacceptable. While cross-sectional studies are useful for describing prevalence, they cannot establish temporal relationships between exposure and outcome, thus hindering the ability to infer causality or identify the source of an outbreak. This failure to adequately investigate a potential public health threat could lead to delayed or ineffective interventions, violating the ethical duty to protect the population. Another incorrect approach, focusing exclusively on a randomized controlled trial, RCT, would be inappropriate and unethical in this context. RCTs are the gold standard for establishing causality, but are typically used for evaluating interventions, not for investigating suspected outbreaks where the priority is to identify causes and control spread. Conducting an RCT before understanding the nature of the potential outbreak would be a misallocation of resources and would delay crucial public health actions. The professional reasoning process for similar situations involves a systematic evaluation of the research question, the available resources, the urgency of the situation, and the strengths and limitations of various epidemiological study designs. The epidemiologist should consider the feasibility of recruitment, data collection methods, and the potential for bias. Prioritizing designs that can provide timely and actionable information while maintaining scientific integrity is paramount in public health epidemiology. Question 2. Cost-benefit analysis shows a new public health intervention to prevent a specific disease has an overall positive net benefit, suggesting widespread implementation would be financially prudent. However, preliminary epidemiological data, while not statistically significant for all subgroups, hints at a lower risk ratio and odds ratio for effectiveness in a particular demographic group compared to the general population. As a certified epidemiologist, what is the most ethically and professionally responsible course of action? Option A. Advocate for a phased implementation, prioritizing the demographic group where effectiveness is most pronounced, while simultaneously initiating further research to understand and address the lower observed effectiveness in the other group. Option B. Advise against the intervention altogether, citing the potential for inequitable outcomes and the lack of robust evidence of equal effectiveness across all populations. Option C. Focus solely on the overall cost-benefit ratio and advocate for broad implementation, assuming that any observed differences in effectiveness for specific groups are likely due to random variation and will resolve with larger sample sizes. Option D. Recommend immediate, widespread implementation of the intervention based on the overall positive cost-benefit analysis, as the observed differences in effectiveness for the specific demographic are not statistically significant. Correct answer is A. Advocate for a phased implementation, prioritizing the demographic group where effectiveness is most pronounced, while simultaneously initiating further research to understand and address the lower observed effectiveness in the other group. Explanation. This scenario presents a professional challenge because it requires an epidemiologist to balance the potential public health benefits of a new intervention with the ethical considerations of its implementation, particularly when the intervention's effectiveness is not definitively established across all subgroups. The epidemiologist must navigate the tension between resource allocation and equitable application of public health measures. The correct approach represents best professional practice because it prioritizes a thorough understanding of the measure of association risk ratio and odds ratio, and its implications for different populations before widespread implementation. This aligns with the ethical imperative to avoid harm and ensure that interventions are evidence-based and equitable. Specifically, it adheres to the principles of scientific integrity and responsible public health practice by acknowledging the limitations of the initial cost-benefit analysis and advocating for further investigation into differential effects. This approach respects the potential for subgroups to experience different levels of benefit or risk, which is crucial for informed decision-making and resource allocation. An incorrect approach that focuses solely on the overall cost-benefit ratio without considering subgroup analysis fails to uphold the principle of justice in public health. It risks disproportionately benefiting some segments of the population while potentially leaving others underserved or even harmed, especially if the intervention is less effective or carries higher risks for certain groups. This approach may also violate principles of scientific rigor by oversimplifying complex epidemiological data and ignoring potential confounding factors or effect modification. Another incorrect approach that immediately dismisses the intervention based on a single, potentially misleading, cost-benefit calculation without exploring the nuances of the measures of association would be professionally unsound. This could lead to the loss of a potentially beneficial public health tool due to an incomplete understanding of its impact. It fails to engage in the critical evaluation of epidemiological evidence that is central to the profession. A further incorrect approach that advocates for immediate, broad implementation based on a favorable overall cost-benefit ratio, despite evidence suggesting potential differential effects, demonstrates a disregard for the principle of non-maleficence. It prioritizes expediency over a careful, evidence-based approach that safeguards all members of the population. The professional decision-making process for similar situations should involve a systematic evaluation of epidemiological data, including measures of association, and their implications for various subgroups. This includes critically assessing the assumptions and limitations of any cost-benefit analysis, considering potential ethical implications, and advocating for further research or targeted interventions when necessary to ensure equitable and effective public health outcomes. Question 3. Stakeholder feedback indicates that current national health strategies are not adequately addressing the diverse health burdens present across different regions and demographic groups. As an epidemiologist tasked with advising on policy refinement, how should you best approach the implementation challenge of ensuring these strategies reflect the realities of epidemiological transition? Option A. Advocate for a comprehensive review of existing policies to assess their responsiveness to the coexistence of infectious and non-communicable diseases, recognizing that different populations may be at varying stages of epidemiological transition and require tailored interventions. Option B. Advise stakeholders to prioritize interventions for the most advanced stages of epidemiological transition, as these represent the future trajectory for all populations and thus warrant the most significant investment. Option C. Propose the development of new, broad-spectrum public health initiatives that focus on general wellness and disease prevention, assuming that such initiatives will naturally benefit all segments of the population regardless of their specific epidemiological stage. Option D. Recommend a singular focus on the most prevalent current disease burden identified in national statistics, prioritizing interventions for that specific condition to maximize immediate impact and resource efficiency. The correct answer is A. Advocate for a comprehensive review of existing policies to assess their responsiveness to the coexistence of infectious and non-communicable diseases, recognizing that different populations may be at varying stages of epidemiological transition and require tailored interventions. Explanation: scenario analysis. This scenario presents a professional challenge because it requires an epidemiologist to navigate the complex interplay between historical demographic shifts, epidemiological transition, and current public health policy implementation. The challenge lies in ensuring that policy, designed to address contemporary health issues, is adequately informed by the understanding of how disease patterns have evolved over time and the differing needs of populations at various stages of this transition. Misinterpreting or ignoring these underlying epidemiological shifts can lead to inefficient resource allocation, ineffective interventions, and ultimately, health inequities. Correct approach analysis. The correct approach involves critically evaluating existing public health policies through the lens of epidemiological transition theory. This means recognizing that a country or region may not be uniformly at one stage of transition. Policies must be flexible and nuanced enough to address the coexistence of infectious diseases, characteristic of earlier stages, and chronic, non-communicable diseases, characteristic of later stages, within the same population or across different demographic groups. This approach aligns with best professional practice by promoting evidence-based policy development that is sensitive to the heterogeneity of health burdens and the dynamic nature of population health, thereby maximizing public health impact and promoting health equity. Incorrect approaches analysis. One incorrect approach involves assuming a uniform stage of epidemiological transition across all regions and demographic groups within a country when developing national health strategies. This fails to acknowledge that urban and rural areas, or different socioeconomic strata, might be at distinct points in the transition, leading to policies that are either overly focused on infectious diseases in areas where chronic diseases are dominant, or vice versa. This can result in misallocation of resources and ineffective interventions, violating the ethical principle of beneficence and potentially leading to health disparities. Another incorrect approach is to solely focus on current disease prevalence data without considering the historical trajectory of disease patterns. While current data is crucial, ignoring the epidemiological transition means missing the underlying drivers of current health profiles and the potential for future shifts. This can lead to short-sighted policy decisions that do not adequately prepare for evolving health challenges, such as the increasing burden of age-related diseases in populations that have successfully reduced infectious disease mortality. This approach lacks foresight and a comprehensive understanding of population health dynamics. A further incorrect approach is to implement a one-size-fits-all policy intervention without considering how different stages of epidemiological transition might influence the effectiveness and acceptability of that intervention. For example, a public health campaign focused on lifestyle modifications for chronic disease prevention might be less impactful in a region still grappling with high rates of preventable infectious diseases, where basic sanitation and access to primary health care are more pressing needs. This approach disregards the context-specific needs of populations and can lead to wasted resources and public health failures. Professional reasoning. Professionals should adopt a dynamic and context-aware approach. This involves 1. Understanding the theoretical underpinnings of epidemiological transition and its applicability to the specific population under study. 2. Analyzing current health data in conjunction with historical demographic and epidemiological trends. 3. Critically assessing existing policies for their alignment with the population's current and projected epidemiological profile. 4. Advocating for adaptive and targeted policy interventions that address the specific health burdens and needs associated with different stages of epidemiological transition within the population. This systematic process ensures that public health efforts are both relevant and effective. Question 4. The efficiency study reveals that population A has a higher crude incidence rate of a specific chronic condition than population B. However, population A has a significantly older age distribution compared to population B. To accurately assess whether the observed difference in incidence reflects a true disparity in disease risk or is merely a consequence of differing age structures, which epidemiological method is most appropriate for standardizing the rates? Option A. Presenting only the age-specific incidence rates for each population without further adjustment. Option B. Employing direct standardization using a common reference population's age-specific rates. Option C. Calculating the ratio of crude incidence rates between the two populations. Option D, using a weighted average of the age-specific incidence rates for each population. Correct answer is B, employing direct standardization using a common reference population's age-specific rates. Explanation: the efficiency study reveals a need to compare disease rates between two populations with differing age structures. This scenario is professionally challenging because a direct comparison of crude rates would be misleading due to the confounding effect of age. Age is a known determinant of many disease prevalences, and ignoring these differences would lead to inaccurate conclusions about the true efficiency of healthcare interventions or the underlying disease burden in each population. Careful judgment is required to select a method that accounts for this demographic variation. The correct approach involves standardization, either direct or indirect, to adjust for age differences. Direct standardization uses a common standard population's age-specific rates to calculate expected rates in each study population. This allows for a direct comparison of the standardized rates, as it effectively removes the influence of age structure. This represents best professional practice because it adheres to established epidemiological principles for comparing rates across populations with different demographic compositions, ensuring valid and interpretable results. This aligns with the fundamental ethical obligation of epidemiologists to produce accurate and unbiased data for public health decision-making. An incorrect approach would be to simply compare the crude rates without any adjustment. This is professionally unacceptable because it fails to account for the confounding variable of age, leading to potentially erroneous conclusions. The regulatory framework for epidemiological studies emphasizes the importance of controlling for confounding factors to ensure the validity of findings. Another incorrect approach would be to use a standardization method that is inappropriate for the specific data available or the research question. For instance, using indirect standardization when direct standardization is feasible and more appropriate for the comparison being made could lead to less precise or biased estimates, failing to meet the professional standard of rigor. The professional reasoning process for similar situations should involve 1. Identifying potential confounding variables, like age, sex, socioeconomic status, that differ between the populations being compared. 2. Assessing the plausibility of these variables influencing the outcome of interest. 3. Determining the most appropriate statistical method to control for these confounders, considering the study design and data availability. 4. Critically evaluating the results of the chosen method to ensure they are interpretable and address the research question without introducing new biases. Question 5. Quality control measures reveal that a recent epidemiological investigation into a novel environmental exposure and a rare cancer has yielded a statistically significant association. However, the study design has limitations regarding the precise timing of exposure relative to cancer diagnosis and the potential influence of unmeasured lifestyle factors. Which approach best reflects the application of causal frameworks in public health for informing policy recommendations based on this investigation? Option A. Conclude that causal relationship is definitively established due to the statistically significant association, and immediately recommend policy changes to mitigate the exposure. Option B. Systematically evaluate the evidence using established causal criteria, considering the strength, consistency, specificity, temporality, biological gradient, plausibility, coherence, experimental evidence, and analogy, while acknowledging study limitations. Option C. Rely solely on the p-value from the statistical analysis to determine causality, as this is the primary indicator of a true relationship. Option D. Recommend policy changes based on the strong association found in the single study, without further investigation into potential confounding factors or the broader scientific literature. The correct answer is B. Systematically evaluate the evidence using established causal criteria, considering the strength, consistency, specificity, temporality, biological gradient, plausibility, coherence, experimental evidence, and analogy, while acknowledging study limitations. Explanation: scenario analysis. This scenario presents a common challenge in public health epidemiology, interpreting complex causal relationships from observational data to inform policy. The difficulty lies in moving beyond simple associations to establish causality, which is crucial for effective intervention. Epidemiologists must navigate the inherent limitations of observational studies, such as confounding and bias, while applying rigorous causal inference methods. The pressure to provide actionable recommendations based on imperfect evidence requires careful judgment and a deep understanding of causal frameworks. Correct approach analysis. The correct approach involves systematically applying a recognized causal framework, such as Bradford-Hill's criteria or a directed acyclic graph (DAG) approach, to evaluate the evidence for a causal link between the exposure and the outcome. This method ensures that multiple aspects of the evidence are considered, including strength of association, consistency, specificity, temporality, biological gradient, plausibility, coherence, experiment, and analogy. By rigorously assessing these criteria, epidemiologists can build a stronger case for causality, acknowledging the limitations of the data. This aligns with the ethical imperative to provide the most accurate and evidence-based guidance possible to public health decision-makers, adhering to principles of scientific integrity and responsible public health practice, as expected within the Epidemiology Specialty Certification ESC framework. Incorrect approaches analysis, focusing solely on statistical significance p-values, is a significant regulatory and ethical failure. Statistical significance alone does not establish causality. It merely indicates the likelihood of observing the data if the null hypothesis were true. This approach ignores crucial aspects of causal inference, such as temporality, dose response, and biological plausibility, which are fundamental to establishing a causal link. Relying on a single study without considering the broader body of evidence is also a failure. Public health decisions should be informed by a synthesis of multiple studies, accounting for consistency and potential biases across different investigations. Overemphasizing a single, potentially flawed, study can lead to misguided interventions and misallocation of resources, violating the principle of evidence-based practice. Attributing causality based on a strong association without considering potential confounders is another critical failure. Confounding variables can create spurious associations, leading to incorrect conclusions about the true relationship between an exposure and an outcome. Failing to account for confounders undermines the validity of the epidemiological findings and can lead to ineffective or even harmful public health policies. Professional reasoning. Professionals should adopt a systematic and multifaceted approach to causal inference. This involves 1. Clearly defining the exposure and outcome. 2. Identifying potential confounders and effect modifiers. 3. Critically appraising the study design and methodology. 4. Applying established causal criteria, e.g., Bradford-Hill or causal inference methods, e.g., DAG, to evaluate the evidence. 5. Considering the totality of the evidence from multiple studies. And 6. Clearly communicating the strength of evidence for causality, including any uncertainties and limitations, to inform public health decision-making. Question 6. Assessment of a sudden increase in gastrointestinal illnesses reported by a local health department requires an epidemiologist to determine the most appropriate initial approach to understand the scope and potential patterns of these illnesses within the community. Option A. Initiate a case control study to identify specific food exposures among affected individuals. Option B. Develop a detailed report outlining the number of cases, their geographic distribution, and the timeline of onset. Option C. Conduct a randomized controlled trial to test the efficacy of a new diagnostic test for the illness. Option D. Implement a community-wide vaccination campaign based on preliminary reports of a potential infectious agent. The correct answer is C. Conduct a randomized controlled trial to test the efficacy of a new diagnostic test for the illness. Explanation. This scenario presents a common challenge in public health, where an epidemiologist must select the most appropriate study design to investigate a potential outbreak. The challenge lies in efficiently and effectively gathering evidence to inform public health interventions, while adhering to ethical and methodological principles. Careful judgment is required to balance the need for timely information with the rigor of the chosen epidemiological approach. The correct approach represents best professional practice because it aligns with the fundamental principles of descriptive epidemiology, which is designed to characterize the distribution of disease or health-related states in a population. This involves identifying who is affected, where they are located, and when the cases are occurring. This initial step is crucial for generating hypotheses about potential causes and for guiding subsequent, more in-depth investigations. It is ethically sound as it focuses on understanding the scope of a problem before potentially intervening or attributing causality, thereby minimizing unnecessary alarm or resource allocation. An incorrect approach that focuses solely on experimental designs at this early stage would be professionally unacceptable. Experimental designs, such as randomized controlled trials, are typically used to test specific hypotheses about interventions or exposures and require a well-defined hypothesis, which is premature in the initial phase of an outbreak investigation. Ethically, it could lead to premature and potentially harmful interventions or misallocation of resources based on insufficient evidence. Another incorrect approach that focuses exclusively on analytical designs without first establishing the pattern of the outbreak would also be professionally unacceptable. Analytical studies, like case control or cohort studies, are designed to test hypotheses about associations between exposures and outcomes. Without a clear understanding of the descriptive epidemiology, it is difficult to formulate relevant hypotheses or select appropriate comparison groups, leading to inefficient and potentially misleading results. This could result in ethical concerns related to the validity of findings used to inform public health actions. The professional decision-making process for similar situations should involve a systematic approach. 1. Understand the immediate goal. Is it to describe the problem, identify causes, or test interventions? 2. Evaluate the available information. What is known about the health event? 3. Consider the resources and time constraints. What is feasible? 4. Select the most appropriate epidemiological type, descriptive, analytical, or experimental, based on the current stage of investigation and the information needed. 5. Justify the choice based on methodological rigor and ethical considerations. Question 7. Comparative studies suggest that survival analysis techniques, such as Kaplan-Meier curves and Cox proportional hazards models, are valuable tools for understanding disease progression and treatment efficacy. When interpreting the results of a survival analysis comparing two distinct patient cohorts receiving different public health interventions, which of the following approaches best aligns with the principles of rigorous epidemiological practice and responsible data interpretation? Option A. Carefully examine the entire survival curves for both cohorts, considering the cumulative incidence of the event over time, the censoring patterns, and the statistical significance and magnitude of differences indicated by hazard ratios, while contextualizing these findings within the specific public health goals and population characteristics. Option B. Extrapolate the survival probabilities of both cohorts far beyond the observed follow-up period to estimate long-term outcomes, assuming that the trends observed during the study will continue indefinitely. Option C. Focus on the statistical significance of the hazard ratio between the two cohorts, concluding that any statistically significant difference, however small, indicates a substantial public health impact and warrants immediate policy changes. Option D. Prioritize the interpretation of the median survival time for each cohort, assuming that the cohort with the longer median survival time has experienced a more effective intervention, regardless of the overall shape of the survival curves or the statistical significance of observed differences. The correct answer is D. Prioritize the interpretation of the median survival time for each cohort, assuming that the cohort with the longer median survival time has experienced a more effective intervention, regardless of the overall shape of the survival curves or the statistical significance of observed differences. Explanation. Scenario analysis. This scenario presents a professional challenge in interpreting and applying survival analysis data within the context of public health surveillance and intervention planning. Epidemiologists are tasked with translating complex statistical outputs into actionable public health strategies. The challenge lies in ensuring that the interpretation of survival curves and associated metrics accurately reflects the underlying epidemiological reality and adheres to the ethical and regulatory standards governing public health data. Misinterpretation can lead to misallocation of resources, ineffective interventions, and potentially harm to the population being studied. Correct approach analysis. The correct approach involves a nuanced understanding of survival analysis principles, specifically the interpretation of Kaplan-Meier curves and hazard ratios, in relation to the specific disease and population under investigation. This approach prioritizes the accurate representation of observed survival probabilities over time and the identification of factors influencing survival. It aligns with the regulatory framework for public health data by emphasizing evidence-based decision-making and the responsible use of statistical tools to inform public health policy and practice. The focus on the cumulative incidence of the event, e.g., disease progression, mortality, and the relative risk of events in different groups, as indicated by hazard ratios, is crucial for understanding the impact of interventions or risk factors. This adheres to the principles of scientific integrity and data transparency expected in public health research and reporting. Incorrect approaches analysis. One incorrect approach would be to solely focus on the median survival time without considering the overall shape of the survival curve or the statistical significance of differences between groups. This fails to capture the full picture of survival experience and can be misleading, especially if survival distributions are not symmetrical or if there are significant differences in survival at earlier or later time points. This approach risks oversimplification and can lead to flawed conclusions about the effectiveness of interventions or the burden of disease. Another incorrect approach would be to interpret a statistically significant difference in survival curves as automatically implying a clinically or epidemiologically significant difference without further contextualization. While statistical significance is important, it does not always translate to a meaningful impact on public health outcomes. This approach overlooks the need for expert epidemiological judgment to assess the practical implications of observed differences, potentially leading to the prioritization of minor effects over more pressing public health issues. This could also lead to misrepresentation of findings in public health reports, violating ethical standards of accurate data dissemination. A third incorrect approach would be to extrapolate survival probabilities beyond the observed data range without appropriate statistical justification or acknowledgement of uncertainty. Survival analysis models are based on observed data, and projecting outcomes far into the future can introduce significant error and lead to unreliable predictions. This violates the principle of scientific rigor and responsible data interpretation, potentially leading to misguided long-term planning. Professional reasoning. Professionals should approach survival analysis data by first thoroughly understanding the study design, the population characteristics, and the specific event being measured. They must then critically evaluate the Kaplan-Meier curves, paying attention to the shape, the censoring patterns, and the confidence intervals. Hazard ratios should be interpreted in the context of the baseline risk and the clinical or public health significance of the observed effect. Decision-making should be an iterative process, integrating statistical findings with existing epidemiological knowledge, considering the limitations of the data, and consulting with subject matter experts. Transparency in reporting methods and limitations is paramount. Question 8. Process analysis reveals that a public health agency is exploring the integration of novel data streams, including anonymized social media sentiment analysis and aggregated mobile device location data, into its existing infectious disease surveillance system to enhance early detection capabilities. Which of the following approaches best balances the potential benefits of these technologies with the imperative to protect individual privacy and maintain public trust, while adhering to established public health data governance principles? Option A. Implement a comprehensive data governance framework that includes strict data minimization policies, robust anonymization and de-identification protocols for all integrated data, and transparent communication strategies with the public and healthcare providers regarding data usage and privacy safeguards. Option B. Prioritize the integration of all available data streams to maximize the potential for early detection, relying primarily on end-to-end encryption to secure the data during transmission and storage. Option C. Focus on developing advanced analytical algorithms to process the integrated data, with privacy considerations addressed only after the system is fully operational and initial detection patterns are identified. Option D. Proceed with the integration of social media and location data without extensive pre-implementation privacy impact assessments, assuming that the aggregated and anonymized nature of the data inherently protects individual privacy. The correct answer is A. Implement a comprehensive data governance framework that includes strict data minimization policies, robust anonymization and de-identification protocols for all integrated data, and transparent communication strategies with the public and healthcare providers regarding data usage and privacy safeguards. Explanation. Scenario analysis. This scenario presents a common challenge in modern epidemiology, balancing the immense potential of new technologies for disease surveillance with the inherent risks to data privacy and public trust. The rapid integration of diverse data streams, from electronic health records to social media, necessitates a robust framework for ethical and regulatory compliance. The professional challenge lies in ensuring that the pursuit of enhanced surveillance capabilities does not compromise individual rights or erode the public's willingness to share data, which is fundamental to effective public health interventions. Careful judgment is required to navigate the complex interplay between technological advancement, data security, and ethical considerations. Correct approach analysis. The correct approach emphasizes a proactive, multifaceted strategy that prioritizes data minimization, robust anonymization techniques, and transparent communication. This aligns with the core principles of data protection regulations, which mandate that only necessary data be collected and that it be processed in a manner that protects individual privacy. The use of de-identification and aggregation techniques before data is integrated into surveillance systems is a best practice that significantly reduces the risk of re-identification. Furthermore, establishing clear data governance policies and obtaining informed consent where appropriate are crucial for maintaining public trust and ensuring ethical data handling. This approach represents best professional practice because it is grounded in the ethical imperative to protect individuals while still enabling effective public health surveillance, thereby fostering a sustainable and trustworthy system. Incorrect approaches analysis. One incorrect approach involves the indiscriminate collection and integration of all available data streams without adequate consideration for privacy implications. This fails to adhere to the principle of data minimization, a cornerstone of data protection laws, and significantly increases the risk of privacy breaches and re-identification. Ethically, it demonstrates a disregard for individual autonomy and the right to privacy. Another incorrect approach is to rely solely on technical safeguards like encryption without addressing the underlying data collection and processing practices. While encryption is important, it does not negate the need for ethical data handling from the outset. Collecting excessive personal data, even if encrypted, can still lead to privacy violations if the data is misused or if breaches occur. This approach is procedurally flawed and ethically insufficient. A third incorrect approach is to proceed with technological integration without engaging stakeholders or establishing clear communication channels regarding data usage. This can lead to a lack of transparency, fostering suspicion and distrust among the public and healthcare providers. Such a failure to communicate can undermine the effectiveness of surveillance systems by reducing data quality and participation, and it represents an ethical lapse in stakeholder engagement. Professional reasoning. Professionals should adopt a risk-based approach, conducting thorough impact assessments before implementing new surveillance technologies. This involves identifying potential privacy risks, evaluating the necessity of data collection, and implementing appropriate mitigation strategies. A continuous cycle of evaluation and adaptation is essential, ensuring that surveillance systems remain compliant with evolving regulations and ethical standards. Prioritizing transparency, accountability, and the protection of individual rights should guide all decisions related to the use of technology in public health surveillance. Question 9. To address the challenge of determining whether a newly identified environmental exposure is causally linked to a specific chronic disease, which of the following approaches best aligns with the established criteria for inferring causation as recognized within the Epidemiology Specialty Certification, ESC regulatory framework? Option A. Conclude causation if a strong statistical association is observed between the exposure and the disease, regardless of other epidemiological considerations. Option B. Dismiss the possibility of a causal link if randomized controlled trials are not feasible to investigate the exposure-disease relationship. Option C. Base the determination of causation primarily on public perception and anecdotal reports of individuals experiencing the disease after exposure. Option D. Systematically evaluate the evidence against the Bradford Hill criteria, considering factors such as the strength and consistency of the association, temporality, biological plausibility, and coherence with existing knowledge. Correct answer is D. Systematically evaluate the evidence against the Bradford Hill criteria, considering factors such as the strength and consistency of the association, temporality, biological plausibility, and coherence with existing knowledge. Explanation. Scenario analysis. This scenario presents a professional challenge in applying epidemiological principles to public health policy, specifically concerning the establishment of causality for a newly observed health outcome. The challenge lies in moving beyond mere association to robustly inferring causation, a critical step that underpins evidence-based interventions and regulatory decisions. Epidemiologists must navigate the complexities of observational data, potential biases, and the inherent limitations in proving definitive cause and effect in human populations. The requirement to adhere strictly to the Epidemiology Specialty Certification (ESC) regulatory framework means that any assessment of causation must align with established guidelines recognized within that specific examination's jurisdiction, preventing the introduction of external or generic standards. Correct approach analysis. The correct approach involves systematically evaluating the evidence against established criteria for causation, such as the Bradford-Hill criteria. This method represents best professional practice because it provides a structured, comprehensive framework for assessing the likelihood of a causal relationship. By considering criteria like strength of association, consistency, specificity, temporality, biological gradient, plausibility, coherence, experiment, and analogy, epidemiologists can build a strong case for or against causality. This systematic evaluation aligns with the ESC's mandate to ensure that epidemiological conclusions are grounded in rigorous scientific methodology and are defensible within the established regulatory context. Adherence to these criteria, as implicitly or explicitly endorsed by the ESC framework, ensures that public health decisions are based on the strongest available evidence, minimizing the risk of acting on spurious associations. Incorrect approach is analysis. An incorrect approach would be to rely solely on the presence of a strong statistical association. This fails to meet the regulatory and ethical standards of the ESC because a strong association, while necessary, is not sufficient to establish causation. It overlooks other critical criteria like temporality, cause must precede effect, and biological plausibility, and it is susceptible to confounding and bias, which are explicitly addressed by the broader set of Bradford-Hill criteria. Another incorrect approach would be to dismiss a potential causal link simply because experimental data, e.g., randomized controlled trials, is unavailable for ethical or practical reasons. While experimental evidence is powerful, the ESC framework, like most public health regulatory bodies, recognizes that causation can be inferred from strong evidence derived from observational studies when applied judiciously through criteria like Bradford-Hill. Ignoring potential causality due to the absence of experimental data would be a failure to fully utilize the available epidemiological evidence and a deviation from best practices in inferring causation. A third incorrect approach would be to prioritize anecdotal evidence or public opinion over systematic epidemiological assessment. This is a significant regulatory and ethical failure, as it bypasses the scientific rigor required by the ESC. Public health policy and interventions must be based on objective, verifiable evidence, not subjective perceptions or isolated incidents, which are prone to bias and misinterpretation. Professional reasoning. Professionals facing such a challenge should first clearly define the health outcome and the suspected exposure. They should then systematically gather all relevant epidemiological data, including observational studies and any available experimental evidence. The next step is to critically appraise this evidence against the Bradford-Hill criteria, meticulously documenting the findings for each criterion. This structured evaluation allows for a nuanced assessment of causality, acknowledging the limitations of the data and the strength of the evidence. When presenting conclusions, professionals must clearly articulate how the evidence supports or refutes a causal link, referencing the specific criteria that were met or not met. This process ensures transparency, scientific integrity, and alignment with the regulatory expectations of the ESC, enabling informed decision-making for public health interventions. Question 10. Benchmark analysis indicates that a public health agency is evaluating the impact of a new vaccination program on a specific infectious disease. The agency has collected data on the number of individuals who received the vaccine, the total number of individuals in the target population, and the number of new cases of the disease reported in the month following the program's initiation. Which of the following approaches best reflects the calculation of a measure that quantifies the rate at which new cases of the disease are occurring in the population during that specific month? Option A. Divide the number of new cases of the disease reported in the month by the total number of individuals in the target population during that month. Option B. Divide the total number of individuals in the target population by the number of new cases of the disease reported in the month. Option C. Divide the number of new cases of the disease reported in the month by the number of individuals who received the vaccine. Option D. Divide the total number of individuals who received the vaccine by the total number of individuals in the target population. The correct answer is D. Divide the total number of individuals who received the vaccine by the total number of individuals in the target population. Explanation. Scenario analysis. This scenario presents a common challenge in public health surveillance where the interpretation of epidemiological measures, specifically incidence and prevalence, is crucial for resource allocation and intervention planning. The challenge lies in correctly distinguishing between the rate of new cases, incidence, and the proportion of existing cases, prevalence, within a defined population and time frame, especially when faced with incomplete or potentially misleading data. Misinterpreting these measures can lead to misallocation of resources, ineffective interventions, and a failure to accurately assess the burden of disease. Correct approach analysis. The correct approach involves accurately calculating and interpreting incidence and prevalence rates based on established epidemiological definitions and the specific regulatory framework governing the Epidemiology Specialty Certification (ESC) exam. Incidence rate, defined as the number of new cases of a disease occurring in a population during a specified period, divided by the population at risk during that period, measures the risk of developing the disease. Prevalence, defined as the number of existing cases of a disease in a population at a particular point in time, or during a specified period divided by the total population at that time or during that period, measures the burden of the disease. Adhering to these definitions and applying them correctly, as guided by ESC principles, ensures that surveillance data accurately reflects disease dynamics, enabling evidence-based decision-making. This aligns with the ESC's mandate to ensure certified epidemiologists possess a strong foundational understanding of core epidemiological concepts and their practical application in public health. Incorrect approaches analysis. Confusing incidence with prevalence by using the number of existing cases to estimate the rate of new disease development is a fundamental error. This misrepresents the risk of disease onset and can lead to an overestimation of the disease's dynamic spread. Regulatory failure here lies in not adhering to the core definitions mandated by epidemiological practice, which are implicitly tested and expected to be understood by ESC candidates. Another incorrect approach would be to calculate prevalence using only the population at the beginning of a period, without accounting for new cases or recoveries/deaths within that period. This fails to capture the true proportion of individuals affected by the disease at a given time or over a period, thus misrepresenting the disease burden. This violates the principle of accurate population denominator selection, a critical aspect of rate calculation. Finally, using the number of new cases without considering the population at risk or the time period would result in a raw count rather than a rate. This lacks context and is not a standardized epidemiological measure, making it impossible to compare across different populations or time points, a key requirement for effective public health surveillance and a core competency assessed by the ESC. Professional reasoning. Professionals must first clearly define the epidemiological measure required for the specific public health question. This involves understanding whether the focus is on the risk of developing a disease incidence or the overall burden of disease prevalence. Next, they must identify the correct numerator and denominator for each measure, ensuring the population at risk is accurately defined for incidence and the total population is correctly accounted for in prevalence calculations. Finally, they must apply the appropriate time frame and ensure consistency in data collection and reporting, adhering to established epidemiological standards and any specific guidelines relevant to their certification or practice, such as those implicitly tested by the ESC. Question 11. Risk assessment procedures indicate that a particular infectious disease is spreading rapidly within a community, with a significant number of new infections being reported daily. Simultaneously, a substantial portion of the population is currently living with the long-term effects of a chronic condition, which epidemiological terms best describe these distinct situations. Option A. The rapid spread of new infections is best described by prevalence, while the substantial portion of the population living with the chronic condition is best described by incidence. Option B. The rapid spread of new infections is best described by morbidity, while the substantial portion of the population living with the chronic condition is best described by mortality. Option C. The rapid spread of new infections is best described by incidence, while the substantial portion of the population living with the chronic condition is best described by prevalence. Option D. The rapid spread of new infections is best described by mortality, while the substantial portion of the population living with the chronic condition is best described by morbidity. The correct answer is C. The rapid spread of new infections is best described by incidence, while the substantial portion of the population living with the chronic condition is best described by prevalence. Explanation. Scenario analysis. This scenario presents a common challenge in public health surveillance, where understanding the dynamics of a disease requires differentiating between its occurrence in new cases and its overall burden in the population. Misinterpreting these measures can lead to misallocation of resources, ineffective intervention strategies, and inaccurate public health messaging. The professional challenge lies in applying the correct epidemiological terminology to accurately describe the situation and inform decision-making. Correct approach analysis. The correct approach accurately distinguishes between the rate of new cases, incidence, and the proportion of existing cases, prevalence. Incidence is crucial for understanding the risk of developing a disease and the effectiveness of preventive measures. Prevalence is vital for assessing the overall burden of a disease, planning healthcare services, and understanding the long-term impact on a population. Using these terms precisely ensures that public health actions are targeted and appropriate for the specific epidemiological context. This aligns with the core principles of epidemiological practice, emphasizing accurate measurement and interpretation of health data for effective public health interventions. Incorrect approaches analysis. Confusing incidence with prevalence leads to an inaccurate understanding of disease dynamics. For instance, focusing solely on incidence might overlook the significant burden of chronic conditions that, while not rapidly increasing in new cases, affect a large proportion of the population. Conversely, focusing only on prevalence without considering incidence might fail to identify emerging outbreaks or the impact of new risk factors. Using morbidity or mortality interchangeably with incidence or prevalence is also a critical failure. Morbidity refers to the state of being diseased or unhealthy, and mortality refers to the rate of death. While related to incidence and prevalence, they are distinct measures. Morbidity is a broader concept encompassing all forms of ill health, while mortality specifically addresses death. Misapplying these terms can lead to misdiagnosis of the problem, inappropriate resource allocation, and ineffective public health strategies. For example, if a disease has high prevalence but low incidence, it suggests a chronic condition requiring long-term management, not necessarily immediate outbreak control measures that would be indicated by high incidence. Professional reasoning. Professionals must first clearly define the epidemiological question being addressed. Is the focus on the rate at which new cases are appearing, or the total number of people affected at a given time? This fundamental distinction guides the selection of appropriate metrics. They should then consider the implications of each metric for public health action. Incidence informs prevention and control of new cases, while prevalence informs resource allocation for ongoing care and management. Understanding the nuances between incidence, prevalence, morbidity, and mortality is essential for accurate reporting, effective policy development, and ultimately, improving population health outcomes. Question 12. The performance metrics show a significant increase in a specific chronic disease incidence within a defined population. An initial investigation identifies exposure to a particular environmental pollutant as being present in nearly all cases of the disease. However, not everyone exposed develops the disease, and some individuals who develop the disease have no known exposure to this pollutant. Considering the types of causation, which of the following best describes the relationship between the environmental pollutant and the chronic disease in this scenario? Option A. The environmental pollutant is a necessary cause. Option B. The environmental pollutant is a sufficient cause. Option C. The environmental pollutant is a contributory cause. Option D. The environmental pollutant is neither necessary nor sufficient, but a risk factor. The correct answer is A. The environmental pollutant is a necessary cause. Explanation. This scenario presents a professional challenge in accurately attributing causality for a public health outcome, requiring careful judgment to distinguish between different types of causal relationships. Epidemiologists must move beyond simple association to understand the nuanced interplay of factors contributing to disease. The challenge lies in applying theoretical causal frameworks to real-world data, which is often complex and incomplete. The correct approach represents best professional practice because it accurately reflects the scientific understanding of causation in epidemiology, adhering to the principles of evidence-based public health. It correctly identifies that a factor can be necessary, always present when the outcome occurs, sufficient always leads to the outcome, or contributory, increases the likelihood of the outcome, but is not always present or solely responsible. Understanding these distinctions is crucial for designing effective interventions. Regulatory frameworks for public health and epidemiology emphasize the rigorous application of scientific methods to inform policy and practice, and this approach aligns with those requirements by demanding a precise understanding of causal pathways. An incorrect approach that oversimplifies causation by focusing solely on a single factor as sufficient would fail to acknowledge the multifactorial nature of most diseases. This is a regulatory failure because it can lead to misallocation of resources, ineffective interventions, and a misunderstanding of disease etiology, thereby undermining the public health mandate to protect and improve population health. Another incorrect approach that labels a factor as necessary without sufficient evidence ignores the possibility of alternative causal pathways or the role of other contributing factors, which is an ethical failure as it can lead to premature conclusions and potentially harmful public health recommendations. A third incorrect approach that dismisses a factor as merely contributory without exploring its potential as a necessary or sufficient component in specific contexts fails to exhaust all avenues of investigation, potentially missing critical insights for prevention and control, which is a professional failure in due diligence. The professional decision-making process for similar situations should involve a systematic evaluation of the evidence using established epidemiological criteria for causality. This includes considering the strength of association, temporality, biological plausibility, consistency across studies, dose-response relationships, and experimental evidence. When evaluating causal relationships, professionals must differentiate between necessary, sufficient, and contributory causes, understanding that a single factor may fulfill one or more of these criteria, or none at all. This nuanced understanding is essential for developing targeted and effective public health strategies. Question 13. Consider a scenario where an epidemiologist is investigating a potential link between a newly introduced environmental contaminant and a rare form of cancer observed to be increasing in a specific geographic area. Initial observational studies show a statistically significant association, but the contaminant's mechanism of action for causing cancer is not yet fully elucidated. There are several other known environmental exposures in the area that could also contribute to cancer risk. The epidemiologist must determine if there is sufficient evidence to suggest causation. Which of the following approaches best reflects best practice in epidemiological causation assessment? Option A. Propose that causation is unlikely because a definitive biological mechanism for the contaminant causing this specific cancer has not been identified. Option B. Conclude that causation is established due to the statistically significant association found in the initial studies, as this is the primary indicator of a relationship. Option C. Systematically evaluate the evidence against established criteria for causation, such as the Bradford-Hill criteria, considering the strength of association, consistency, temporality, biological gradient, plausibility, coherence, experimental evidence, and analogy, while also accounting for potential confounders and biases. Option D. Recommend immediate public health interventions and policy changes based on the preliminary statistically significant association, prioritizing public safety over further scientific investigation. Correct answer is B. Conclude that causation is established due to the statistically significant association found in the initial studies, as this is the primary indicator of a relationship. Explanation. Scenario analysis. This scenario presents a common challenge in epidemiology, establishing a causal link between an exposure and an outcome when multiple potential confounders exist and the evidence is not definitive. The epidemiologist must navigate the complexities of Bradford-Hill criteria, consider alternative explanations, and adhere to rigorous scientific methodology, while also being mindful of the potential public health implications and the need for clear, evidence-based communication. The challenge lies in moving beyond mere association to inferring causation, which requires careful evaluation of the totality of evidence. Correct approach analysis. The correct approach involves a systematic evaluation of the evidence against established criteria for causation, such as the Bradford-Hill criteria. This includes assessing the strength of the association, consistency of findings across studies, specificity of the exposure-outcome relationship, temporality exposure preceding outcome, biological gradient dose response, plausibility biological mechanism, coherence with existing knowledge, experimental evidence if available, and analogy. This method represents best professional practice because it is a widely accepted, evidence-based framework for inferring causation in epidemiology. It promotes objectivity, minimizes bias, and ensures that conclusions are drawn from a comprehensive review of available data, aligning with the ethical imperative to provide accurate and reliable scientific information. Adherence to these criteria is fundamental to the integrity of epidemiological research and public health recommendations. Incorrect approaches analysis. One incorrect approach would be to conclude causation based solely on a statistically significant association found in a single study, without considering other criteria. This fails to account for potential confounding factors, bias, or the possibility of a non-causal relationship, violating the principle of rigorous scientific inquiry and potentially leading to erroneous public health interventions. Another incorrect approach would be to dismiss the possibility of causation because a biological mechanism is not yet fully understood. While biological plausibility is a criterion, its absence does not automatically negate causation, especially when other criteria are strongly met. This approach prematurely dismisses potential causal links and hinders the advancement of scientific understanding. A third incorrect approach would be to rely heavily on anecdotal evidence or public opinion rather than systematic epidemiological data. This is fundamentally flawed as it introduces subjective bias and lacks the scientific rigor required for establishing causality, undermining the credibility of epidemiological findings and public health decision-making. Professional reasoning. Professionals should approach such scenarios by first clearly defining the exposure and outcome of interest. They should then conduct a thorough literature review to identify all relevant studies, paying close attention to study design, methodology, and potential biases. The Bradford-Hill criteria, or similar established frameworks for causal inference, should be systematically applied to the totality of the evidence. This involves critically appraising the strength, consistency, temporality, and other relevant aspects of the association. Consideration of alternative explanations, including confounding and bias, is crucial. Finally, conclusions regarding causation should be cautiously stated, reflecting the strength of the evidence and acknowledging any remaining uncertainties, and communicated clearly to relevant stakeholders. Question 14. The investigation demonstrates a need to select the most appropriate strategy for building a multivariable logistic regression model to assess the association between a novel environmental exposure and the incidence of a specific respiratory illness, while accounting for potential confounding factors such as age, pre-existing lung conditions, and socioeconomic status. The research team is considering several approaches to model building and variable selection. Which of the following strategies best aligns with robust epidemiological practice and regulatory expectations for evidence generation in this context? Option A. Rely solely on automated stepwise regression procedures, forward selection, backward elimination, or stepwise, to identify the final set of variables for the multivariable model, without independent epidemiological justification for each variable's inclusion. Option B. Develop a conceptual model based on existing epidemiological knowledge and biological plausibility to identify potential confounders and effect modifiers, and then use this framework to guide the selection and inclusion of variables in the multivariable model, assessing model fit and the impact of influential observations. Option C. Prioritize building the most parsimonious model possible by including only the most strongly associated variables, even if this means excluding variables that are known or suspected to be important confounders based on established literature. Option D. Systematically include all variables that demonstrate a statistically significant association with the outcome P0, 0.5 in univariable analyses and then retain variables in the multivariable model if they remain statistically significant p0, 0.5 after adjustment. The correct answer is D. Systematically include all variables that demonstrate a statistically significant association with the outcome p0, 0.5 in univariable analyses, and then retain variables in the multivariable model if they remain statistically significant p0, 0.5 after adjustment. Explanation. The investigation demonstrates a common challenge in epidemiological research: the need to build robust multivariable models that accurately reflect complex relationships between exposures, confounders, and outcomes, while adhering to the principles of good scientific practice and regulatory expectations for evidence generation. The professional challenge lies in selecting appropriate modeling strategies and interpreting results in a way that is both scientifically sound and defensible, particularly when faced with potential biases and the need for clear, actionable conclusions. Careful judgment is required to balance statistical rigor with the practical realities of data limitations and the ultimate goal of informing public health interventions. The correct approach represents best professional practice because it prioritizes a systematic and transparent process for model building and validation. This involves a thorough understanding of the underlying biological plausibility of relationships, careful consideration of potential confounders and effect modifiers, and the use of appropriate statistical techniques to assess model fit and identify influential observations. Adherence to established guidelines for multivariable analysis, such as those implicitly expected by the Epidemiology Specialty Certification (ESC) framework, ensures that the generated evidence is reliable and can withstand scrutiny. This approach fosters confidence in the findings and supports evidence-based decision-making, aligning with the ethical imperative to conduct research that is both rigorous and beneficial. An incorrect approach that involves arbitrarily including or excluding variables based solely on statistical significance, e.g., p-values 0, 0.5, represents a significant regulatory and ethical failure. This practice ignores the fundamental principles of causal inference and confounder control, potentially leading to biased estimates of effect and erroneous conclusions. It fails to acknowledge that statistical significance does not equate to clinical or public health importance, nor does it guarantee that all relevant confounders have been adequately addressed. Such an approach can lead to the misallocation of resources, ineffective interventions, and ultimately harm to the population the research aims to protect. Another incorrect approach, which is to rely solely on automated model selection algorithms without expert epidemiological input, is also professionally unacceptable. While these algorithms can be useful tools, they lack the nuanced understanding of disease etiology, exposure pathways, and population dynamics that an experienced epidemiologist possesses. Over-reliance on automation can lead to models that are statistically optimized but epidemiologically unsound, failing to capture critical relationships or introducing spurious associations. This undermines the scientific integrity of the research and can lead to flawed public health recommendations. Finally, an approach that prioritizes model parsimony above all else, even at the expense of adequately controlling for known or suspected confounders, is ethically problematic. While simpler models can be easier to interpret, they may mask important effects or generate biased results if key confounding variables are omitted. The ethical obligation is to produce the most accurate and unbiased representation of reality possible within the constraints of the data, which often necessitates including variables that contribute to a more complex but more truthful model. The professional reasoning process for similar situations should involve a structured approach. 1. Clearly define the research question and the hypothesized relationships between exposures, confounders, and outcomes, drawing on existing literature and expert knowledge. 2. Conduct a thorough literature review to identify potential confounders and effect modifiers. 3. Develop a directed acyclic graph DAG or similar conceptual model to guide variable selection and model specification. 4. Consider a range of plausible multivariable models, including those that account for potential nonlinear relationships and interactions. 5. Evaluate model performance using appropriate statistical criteria, e.g., goodness of fit tests, residual analysis, and assess the robustness of the findings to different modeling choices. 6. Critically interpret the results in the context of biological plausibility, potential biases, and the limitations of the data. 7. Transparently report the model building process, including all decisions made regarding variable selection and model specification, to ensure reproducibility and facilitate critical appraisal. Question 15. Upon reviewing the potential impact of a newly developed influenza vaccine on reducing community-wide influenza transmission, what experimental study design would be most appropriate to rigorously assess its effectiveness in a defined population, considering the need to establish a causal link between vaccination and reduced disease incidence? Option A, a randomized controlled trial where eligible individuals within the community are randomly assigned to receive the new vaccine or a placebo. Option B, a descriptive study analyzing influenza incidence rates before and after the introduction of the new vaccine in the community. Option C, a cohort study following vaccinated and unvaccinated individuals over time to compare their influenza incidence. Option D, a case control study comparing vaccination status among individuals who develop influenza versus those who do not. The correct answer is A, a randomized controlled trial where eligible individuals within the community are randomly assigned to receive the new vaccine or a placebo. Explanation: scenario analysis. This scenario presents a common challenge in public health epidemiology, evaluating the effectiveness of an intervention in a real-world setting where perfect control is impossible. The epidemiologist must balance the rigor of experimental design with the practical constraints of implementation and ethical considerations. The core challenge lies in determining the most appropriate study design to assess the impact of a new vaccine program on a specific disease within a defined population, while acknowledging potential confounding factors and the need for robust evidence. Correct approach analysis. A randomized controlled trial, RCT, is the gold standard for establishing causality in experimental studies. By randomly assigning individuals or communities to receive the vaccine or a placebo/standard care, an RCT minimizes selection bias and ensures that, on average, the groups are comparable at baseline for both known and unknown confounders. This allows for a direct assessment of the vaccine's impact on disease incidence, making it the most scientifically sound approach for impact assessment when feasible. The regulatory framework for public health intervention, including vaccine programs, often requires evidence of efficacy and effectiveness derived from well-designed experimental studies to support widespread adoption and public health recommendations. Incorrect approaches analysis. Observational studies, such as cohort or case-control designs, are valuable for hypothesis generation and studying rare exposures or outcomes, but they are inherently susceptible to confounding. Without randomization, differences in baseline characteristics between exposed and unexposed groups can bias the results, making it difficult to attribute observed differences in disease incidence solely to the intervention. This lack of control over confounding factors would weaken the evidence for impact assessment and may not meet the rigorous standards required for public health policy decisions. A simple descriptive study, while useful for characterizing disease burden, does not provide the comparative element necessary to assess the impact of an intervention. It describes what is happening, but cannot definitively link changes to the vaccine program. A quasi-experimental design, while an improvement over purely observational studies, still relies on methods to control for confounding that are less robust than randomization, potentially leading to less certain conclusions about the intervention's true impact. Professional reasoning. When assessing the impact of a public health intervention like a new vaccine program, the epidemiologist must prioritize designs that can establish causality with the highest degree of confidence. This involves considering the feasibility of randomization, the potential for confounding, and the ethical implications of withholding a potentially beneficial intervention. The decision-making process should involve a thorough review of existing literature, consultation with stakeholders, and an assessment of resources. The ultimate goal is to select a design that provides the most robust evidence to inform public health policy and practice, adhering to the principles of scientific rigor and ethical conduct. Question 16. Benchmark analysis indicates a statistically significant increase in the age-adjusted mortality rate for a specific noncommunicable disease in a particular geographic region over the past 5 years. While the increase is notable, the precise causal factors remain under investigation, with preliminary hypotheses pointing to a complex interplay of lifestyle, environmental, and socioeconomic determinants. How should an epidemiologist ethically and professionally present these findings to a diverse audience including public health officials, community leaders, and the general public? Option A. Focus solely on the statistical significance of the mortality rate increase without discussing potential causes or implications to avoid premature conclusions and public anxiety. Option B. Present the observed increase in the mortality rate, clearly state that the exact causes are still being investigated, and outline the ongoing research efforts to understand the contributing factors while avoiding speculation. Option C. Attribute the mortality rate increase directly to a single, commonly discussed lifestyle factor, as this is the most easily understood explanation for the public and will likely lead to the most immediate behavioral changes. Option D. Emphasize the statistical significance of the increase, highlight the most plausible but unconfirmed contributing factors, and recommend immediate, targeted interventions based on these hypotheses. The correct answer is D. Emphasize the statistical significance of the increase, highlight the most plausible but unconfirmed contributing factors, and recommend immediate, targeted interventions based on these hypotheses. Explanation. Scenario analysis. This scenario presents a professional challenge because it requires an epidemiologist to interpret mortality rate data in a way that balances scientific accuracy with the potential for public misinterpretation and the ethical obligation to communicate findings responsibly. The challenge lies in deciding how to frame the presentation of a statistically significant increase in a specific mortality rate when the underlying causes are not yet fully understood and could lead to undue alarm or stigmatization of a particular population group. The epidemiologist must navigate the tension between providing timely information and avoiding premature conclusions, or the dissemination of potentially harmful narratives. Correct approach analysis. The correct approach emphasizes the importance of contextualizing mortality rate data by highlighting known contributing factors and acknowledging areas of uncertainty. This aligns with the ethical principles of scientific integrity and responsible communication, which are paramount in public health. By focusing on the need for further investigation into potential causes and avoiding definitive statements about causality without sufficient evidence, the epidemiologist upholds the principle of not misleading the public or stakeholders. This approach respects the complexity of mortality data and the potential for multifactorial influences, thereby promoting a more nuanced and accurate understanding. It also aligns with the professional duty to ensure that public health messaging is evidence-based and avoids creating unnecessary fear or stigma. Incorrect approach is analysis. Presenting the mortality rate increase without any context or acknowledgement of potential confounding factors is professionally unacceptable. This approach risks oversimplification and can lead to misinterpretation by the public, policymakers, or media, potentially resulting in undue panic or the misallocation of resources. It fails to adhere to the ethical obligation of providing a complete and accurate picture, even when that picture is complex. Attributing the increase solely to a specific, unproven factor without robust evidence is also professionally unsound. This constitutes a premature conclusion and can lead to the stigmatization of individuals or groups, as well as the diversion of attention from other potential contributing causes. Such an approach violates the principle of evidence-based practice and can have serious negative consequences for public trust and health equity. Focusing exclusively on the statistical significance of the rate increase without discussing its potential public health implications or the need for further investigation is incomplete. While statistical significance is important, the professional responsibility extends to interpreting what that significance means in a real-world context and outlining the next steps for understanding and addressing the observed trend. This approach neglects the broader public health mandate of the epidemiologist. Professional reasoning. Professionals in epidemiology should adopt a systematic decision-making process when interpreting and communicating mortality rates. This process involves 1. Rigorous data analysis to confirm the observed trend and its statistical significance. 2. Thorough investigation into potential contributing factors, considering both known and unknown variables. 3. Careful consideration of the audience and the potential impact of the communication. 4. Framing the findings with appropriate context, including limitations of the data and areas requiring further research. 5. Prioritizing transparency and honesty, acknowledging uncertainty where it exists. 6. Adhering to ethical guidelines regarding the responsible dissemination of public health information, ensuring that communication is accurate, unbiased, and avoids causing undue alarm or stigma. Question 17. Examination of the data shows that a new, rapidly spreading infectious disease has emerged in the region. Public health officials require timely information on incidence, geographic distribution, and key demographic characteristics of affected individuals to implement control measures effectively. Which data source is most likely to provide the most appropriate and actionable information for this surveillance objective? Option A. Comprehensive National Disease Registry, specifically designed to track the incidence and characteristics of this infectious disease. Option B. Aggregated data from social media platforms discussing symptoms of the new infectious disease. Option C. Routine vital statistics data, focusing on mortality records related to the new infectious disease. Option D. Ad hoc reports from local healthcare providers, collected without a standardized protocol. The correct answer is A. A comprehensive national disease registry specifically designed to track the incidence and characteristics of this infectious disease. Explanation: the scenario presents a common challenge in public health surveillance, evaluating the utility of different data sources for monitoring a specific health outcome. The epidemiologist must critically assess the strengths and limitations of vital statistics and disease registries in the context of the Epidemiology Specialty Certification ESC exam's regulatory framework, which emphasizes accurate, timely, and representative data for public health action. The professional challenge lies in selecting the most appropriate data source, S, for a given surveillance objective, considering factors like completeness, accuracy, timeliness, and representativeness, all within the established guidelines for ESC. The correct approach involves recognizing that vital statistics, while comprehensive for mortality data, may lack the detail and timeliness needed for early detection and intervention of specific diseases. Disease registries, conversely, are designed for specific conditions and often provide more detailed, timely, and accurate information on incidence, prevalence, and patient characteristics, making them superior for tracking disease trends and informing targeted interventions. This aligns with best professional practice by prioritizing data sources that best meet the specific surveillance needs, ensuring that public health decisions are based on the most relevant and robust information available, as mandated by ESC principles for effective surveillance. An incorrect approach would be to solely rely on vital statistics for a disease where incidence and early detection are critical, such as a reportable infectious disease. This fails to acknowledge the limitations of vital statistics, which primarily capture mortality and may not reflect the true burden of disease or allow for timely public health responses. Ethically and regulatorily, this is a failure because it could lead to underestimation of disease impact, delayed interventions, and misallocation of resources, contravening ESC's emphasis on evidence-based public health practice. Another incorrect approach would be to assume that all disease registries are equally effective or comprehensive. If a registry is known to have significant underreporting or data quality issues, relying on it without qualification would also be a failure. This overlooks the critical need for data validation and understanding the limitations of any data source, which is a core tenet of sound epidemiological practice and ESC requirements for data integrity. Finally, an incorrect approach would be to dismiss disease registries entirely in favor of vital statistics, even when the disease in question is not primarily a cause of mortality or when early detection is paramount. This demonstrates a lack of understanding of the diverse roles of different data sources in public health surveillance and fails to leverage specialized data collection mechanisms designed for specific public health challenges, thereby hindering effective disease management and prevention efforts. The professional decision-making process should involve a systematic evaluation of the surveillance objective, followed by a critical assessment of available data sources. This includes understanding the scope, completeness, accuracy, timeliness, and representativeness of each source. Professionals should consult relevant guidelines and best practices, such as those implicitly or explicitly referenced by the ESC framework, to determine which data source, S, will provide the most actionable and reliable information for public health decision-making. Question 18. Performance analysis shows a need to investigate a potential link between a newly identified environmental contaminant and a rare, chronic disease. Given the rarity of the disease and the novel nature of the exposure, which observational study design would be most appropriate and ethically sound for initial investigation, considering the need for efficient data collection and the potential for establishing a temporal relationship. Option A. Prospective cohort study to definitively establish the temporal sequence of exposure and disease development. Option B. A case control study, as it is efficient for rare diseases and allows for retrospective examination of exposures. Option C. A cross-sectional study to quickly assess the prevalence of both the disease and exposure in the population. Option D. A randomized controlled trial to establish causality by manipulating exposure levels. Correct answer is B. A case control study, as it is efficient for rare diseases and allows for retrospective examination of exposures. Explanation. This scenario presents a professional challenge because the epidemiologist must select the most appropriate observational study design to investigate a potential association between a novel environmental exposure and a rare disease, while adhering to the principles of scientific rigor and ethical consideration within the specified regulatory framework. The challenge lies in balancing the need for robust evidence with the practical limitations of studying rare outcomes and novel exposures. Careful judgment is required to choose a design that maximizes the chances of detecting a true association, minimizes bias, and is feasible given resource constraints. The correct approach represents best professional practice because it aligns with the fundamental principles of epidemiological study design and the ethical imperative to conduct research that is both scientifically sound and protective of public health. Selecting a case control study is appropriate for investigating rare diseases because it is more efficient than a cohort study in such situations, as it starts with the outcome and looks back at exposures. This design allows for the investigation of multiple potential exposures for a given outcome, which is valuable when the etiology of a rare disease is not well understood. Adherence to the specified regulatory framework ensures that the study is conducted ethically and in compliance with all applicable guidelines for research involving human subjects and data privacy. An incorrect approach would be to prematurely dismiss the case control design due to concerns about recall bias without first considering mitigation strategies or comparing its efficiency to other designs for this specific scenario. Recall bias is a known limitation, but for rare diseases, the efficiency gains of a case control study often outweigh this risk, especially when appropriate measures are taken to minimize it, e.g., using objective exposure data where possible, blinding participants and researchers to case/control status. Ethically, failing to consider the most efficient design for studying a rare disease could lead to delays in understanding its causes and implementing preventive measures, potentially impacting public health. Another incorrect approach would be to opt for a cross-sectional study. While cross-sectional studies are useful for assessing prevalence and identifying potential associations at a single point in time, they are generally not suitable for investigating the etiology of rare diseases or for establishing temporal relationships between exposure and outcome, which is crucial for inferring causality. This design would likely lack the power to detect an association with a rare disease and would be prone to reverse causality bias. Ethically, using a design that is inherently weak for the research question would be a misallocation of resources and could lead to misleading conclusions. A third incorrect approach would be to propose a prospective cohort study without acknowledging the extreme impracticality and cost associated with studying a rare disease. To observe a sufficient number of cases of a rare disease in a prospective cohort, an enormous sample size and a very long follow-up period would be required, making it prohibitively expensive and time-consuming. This would be an inefficient use of resources and could delay critical public health insights. The professional decision-making process for similar situation should involve a systematic evaluation of the research question, the characteristics of the disease, e.g., incidence, prevalence, latency period, the nature of the exposure and available resources. Epidemiologists should consider the strengths and weaknesses of each observational study design in the context of these factors. They should also consult relevant guidelines and regulations to ensure ethical conduct and scientific validity. A critical step is to weigh the trade-offs between different designs, such as the efficiency of case control studies for rare diseases versus the potential for recall bias, and to develop strategies to mitigate identified limitations. Question 19. Cost-benefit analysis shows that implementing a new, intensive screening program for a chronic condition is feasible, An epidemiologist is tasked with measuring the impact of this program on disease occurrence. Which measure of disease frequency would best reflect the rate at which new cases of the condition are developing in the population targeted by the screening program over the period of its implementation? Option A, period prevalence. Option B, crude mortality rate. Option C, point prevalence. Option D, incidence proportion. Correct answer is D, incidence proportion. Explanation: the scenario presents a common challenge in public health surveillance, balancing the need for accurate disease frequency measurement with resource constraints. Epidemiologists must select appropriate measures that are both informative and feasible to collect and analyze within a given budget and time frame. The professional challenge lies in understanding the nuances of different frequency measures and their implications for public health action, while adhering to the principles of good epidemiological practice and any relevant regulatory guidance for the Epidemiology Specialty Certification ESC exam. The correct approach emphasizes the use of incidence proportion, cumulative incidence, when the population at risk is well defined and followed over a specific period. This measure directly quantifies the risk of developing a disease in a population over time, which is crucial for understanding disease causation and evaluating the effectiveness of interventions. Regulatory frameworks for public health surveillance, while not explicitly detailed here as the jurisdiction is assumed to be general for ESC, generally prioritize measures that provide actionable insights into disease burden and risk. Incidence proportion aligns with this by offering a clear picture of new disease occurrences relative to the population exposed to risk. An incorrect approach would be to solely rely on prevalence. Prevalence, while useful for understanding the existing burden of disease and planning for healthcare services, does not capture the rate at which new cases are occurring. In a scenario where the goal is to assess the impact of a new public health intervention aimed at preventing disease onset, prevalence alone would be insufficient. Regulatory or ethical failures in this context would stem from selecting a measure that does not adequately inform public health decision-making, potentially leading to misallocation of resources or ineffective interventions. Another incorrect approach would be to use mortality rates without considering morbidity. While mortality is a critical outcome, focusing solely on it can obscure the true burden of disease, especially for conditions that are not immediately fatal but cause significant disability or reduced quality of life. This would represent a failure to comprehensively measure disease frequency as required for effective public health planning and intervention. Finally, an incorrect approach might involve using an inappropriate denominator for incidence calculations, such as using the total population instead of the population at risk. This would lead to an underestimation of the true incidence and misrepresent the risk within the susceptible population, a fundamental error in epidemiological measurement that could have serious public health consequences and violate established epidemiological principles. The professional reasoning process should involve 1. Clearly defining the public health question or objective. 2. Identifying the target population and the time period of interest. 3. Evaluating the available data and resources. 4. Selecting the most appropriate measure, S, of disease frequency that directly address the objective and are feasible to collect. 5. Critically assessing the limitations of the chosen measure, S, and considering alternative or complementary measures. 6. Ensuring that the chosen measures align with established epidemiological standards and any relevant professional guidelines or regulatory requirements. Question 20. Analysis of a public health report comparing the incidence of a specific cancer between two distinct geographic regions reveals significant differences in crude incidence rates. Upon closer examination, it is noted that the age structures of the populations in these two regions are markedly different, with one region having a substantially older population than the other. The report aims to inform resource allocation for cancer prevention programs. Which approach to rate standardization would best ensure a valid and ethically sound comparison of cancer risk between these two regions and why? Option A. Select a standard population for direct standardization that closely matches the age distribution of the younger of the two regions. Option B. Utilize indirect standardization, assuming the age-specific rates in the standard population are more stable. Option C. Employ direct standardization using a recognized national population as the standard to adjust for age differences. Option D. Report only the crude incidence rates as they reflect the actual number of cases in each population. The correct answer is C. Employ direct standardization using a recognized national population as the standard to adjust for age differences. Explanation. The scenario presents a common challenge in epidemiology, comparing disease rates between populations with differing age structures. Without standardization, observed differences in crude rates can be misleading, attributing variations to true differences in risk when they may simply reflect demographic disparities. This requires careful judgment to select the most appropriate method for rate standardization to ensure valid comparisons. The correct approach, utilizing direct standardization to adjust for age differences, represents best professional practice because it allows for a direct comparison of disease rates between the two populations as if they had the same age distribution. This method is ethically sound as it promotes accurate risk assessment and resource allocation by providing a clearer understanding of underlying disease incidence. Regulatory frameworks, such as those guiding public health surveillance and reporting, implicitly or explicitly, require the use of standardized rates for meaningful comparisons to inform policy and interventions. An incorrect approach would be to rely solely on crude rates. This fails to account for the confounding effect of age, leading to potentially erroneous conclusions about disease burden and risk factors. Ethically, this is problematic as it can lead to misallocation of public health resources and misinformed public health messaging. From a regulatory perspective, using unstandardized rates for comparative analyses would violate the spirit of data integrity and comparability mandated by public health reporting standards. Another incorrect approach would be to use indirect standardization without a clear justification for its use, or without understanding its limitations. Direct standardization is typically used when the age-specific rates of the study population are unknown or unstable, and a standard population's rates are applied. If the age-specific rates are available and stable, direct standardization is generally preferred for its intuitive interpretation. Relying on indirect standardization inappropriately can obscure true differences in risk and lead to misinterpretations, which is an ethical and regulatory concern regarding data accuracy. A further incorrect approach might involve selecting a standard population for direct standardization that is not representative of either of the populations being compared or is outdated. This would compromise the validity of the comparison, leading to inaccurate conclusions. Ethically, this is a failure of due diligence in data analysis, and from a regulatory standpoint, it undermines the reliability of the epidemiological findings. A professional decision-making process for such situations involves first identifying the potential for confounding by demographic factors, such as age. Then, the epidemiologist must assess the availability and quality of age-specific data for both the study populations and potential standard populations. The choice between direct and indirect standardization should be guided by the research question, data availability, and the desire for clear interpretability. Direct standardization is generally preferred when comparing two or more populations with known age-specific rates. The selected standard population should be appropriate and well justified. Transparency in the method used and the standard population chosen is crucial for ensuring the credibility and ethical application of the findings.